Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Muhammad Sobhi for this elegant meeting and inviting me. I'm really happy to be here today. My case presentation, it's about male patient, 70 years old. He complaining of shortness of breath, dyspnea, paroxysmal nocturnal dyspnea. He has attacks of typical chest pain. And clinically, his weight is only 6 kilograms. His blood pressure is 90/50. His heart rate 100 beats per minute. He has bilateral diminished air entry at his basal lungs, and his creatinine level slightly high. Creatinine clearance less than is or equal to 30 milli per minute. And his hemoglobin is only 10 gram per deciliter. And this is his ECG and his chest X-ray, and you can appreciate he has left pleural effusion. And this is his echo. Has significant aortic stenosis with mild mitral regurg. His ejection fraction is only 25%, with mean gradient is 42 millimeter mercury. And this is his CT. And we have to stop here because the CT has a lot of data not amenable for TAVI. First of all, his bicuspid aortic valve, as you can appreciate there, that there is fusion of the commissures by calcium, and the height of left main to the annulus is only 7.4 millimeter. And as Professor Nabil Farag mentioned, that we have absolute contraindication for TAVI when we have annulus like that, height left main to annulus like that. So let us see his coronary angiography. This is the second surprise. He has significant lesion at the middle LED, subtotal lesion, has non-dominant circ with mid lesion, and his right coronary artery diseased from the beginning, and before crux is totally occluded. And when we calculate his risk scores, it's very high risk for mortality and very high risk for morbidity. And this is calculated by ST score, which is dedicated for surgery when you would attempt to do CABG with aortic valve replacement. And this is his Euroscore. So it's very high. Euroscore is 56 and ST score is 10. So the challenge in this case is high risk score for surgery. This patient has coronary artery disease, 3-vessel disease, and severe aortic stenosis. He has renal impairment with low ejection fraction. And the most difficult thing is the anatomical issue that this patient has low-seated left main to aortic annulus, and he has bicuspid aortic valve. So, how would you treat this patient? We can open the discussion now.
I think there is many ways to do it, but the simple one is to do bilateral capacity. So by doing bilateral capacity, you may improve the renal function of the patient, you may improve the ejection fraction, and then this very high risk patient for surgery may become intermediate risk for surgery, or even low risk for surgery. Because I've seen a lot of cases where ejection fraction went up to 45, 50 within 2 or 3 weeks. Renal function increasing, and then you can have the possibility to do surgery or PCI plus TAVI. But in this case, it's a little complex patient is casualty in shock with malodor interest in the active space. And the patient recovers so much. He was very old. We have done the TAPI 3 weeks later, but the condition of the patient was completely different. We have a couple of maybe
so I think we all agree that this patient is a poor candidate for surgery with cavitation plus. So this patient is really a poor candidate for surgery with cavitation or hyperventilation. Maybe a good option because you will need to treat the coronary first. So maybe a good option is to treat the coronary and then see if the LV improve, if the patient goes better, and re-ask yourself if it is a more TAVI candidate or a surgical candidate. But if you have to do TAVI, it's tricky, but it's possible.
Yeah.
I think that the balloon is very useful on many levels. Besides getting you a better hemodynamic shape, it will give you an idea how that left hospital behaves in the hospital better than. But equally important, ejection fraction per se doesn't really say much. I mean, it is 25% uncompensated and not in heart failure with West measured at 2022. I would honestly go fix the colonies, obviously intensive using imaging to minimize contrast, give it a week, 10 days to recover, and then go for the damage straight away rather than an automatic dust. I think at 69 years old, if he's not paid and otherwise a very good functional individual, and not an active heart failure, there is little to gain clinically from a pneumotic valvuloplasty, which can be useful in a patient who is otherwise a cardiogenic shock or a crashing in the last thing I would want to say about left main, his sinuses are quite wide, and I'm assuming we went for an eminent valve on this occasion, and with eminence, it is the width of the sinus rather than the coronary height which matters the most. Perhaps it is vice versa with balloon expansion of that, but I honestly think that the anatomy is not that bad in terms of
It was wrong.
Yeah.
Maybe because it improved their function, like this keep surgery. Because if you do the problems, then I think surgical risk would not be that high.
Yeah. So this is my thoughts. Surgery versus BCI and TAVI. All versus staged procedure, as you mentioned, Professor Adel, to do coronaries first and then to see if the patient improved, as Gandhi mentioned, which valve, and I think this is very important. When we look to the CT, if this patient has narrow sinuses, this patient completely will refuse for TAVI. But when we have a shorter height of left main to the annulus, we have to look to the width of sinuses of the valve. And if we have wide sinuses, more than 27, 28 for valve 26, it will be okay. Why? Because the leaflets, when embedded behind the valve, it will not include the left main. When you have large sinuses enough for this valve. And how to protect the left main. So what I did, we staged the procedure to do first BCI, and then after 2 weeks we will see. This is BCI to the LED, and you can appreciate here how his ejection fraction is low. And this is his right coronary artery, and this is the end result of the right coronary artery. And after 2 weeks, the patient slightly improved, and we took the decision to do TAVI. But which strategy to do TAVI? We have two strategies. To inflate balloon first and give injection and see how the coronaries behave. when you occlude the LV outflow tract and when the leaflets behind the balloon. And we can protect the left main by putting guiding and wiring of the LED and stent, deflated stent in the LED. And when you dislodge your guiding in the ascending aorta and deploy the valve. And if the left main affected, you can pull your stent and inflate the left main to protect this left main. And this is balloon. You can see here, we see the left main, we see the right coronary artery. Maybe the flow in the left main better than the right coronary artery, and the left main is low. And because I have wide sinuses, I decided to go to 26 millimeter valve, and this is recapture valve. If the patient affected hemodynamically, if the patient has occlusion of the left main, I can pull the valve outside.
You mean before full deployment, you say?
No,
And something
not full deployment. Before deployment, 80% from the valve. And you can see here, this is step-by-step release of the valve. And this is the end result. We have mild paravalvular leakage. And what I did here to get angio for the left main. You can see here the caster obstructing the new leaflets, so the regurgitation is high, but the left side that showed that the good result after deployment of the valve.
Yes, sir, can I stop you here and ask you and the panel? Now, we've been battling to some extent with the difficult concept of delayed coronary obstruction. So any clues and how would you, to the instance of delayed coronary obstruction, you come out, the left main is good flow, and within 2 to 3, it happens up to a week later, although the incidence is not high, but it is in the early 10 to 11, 12%. So, Dr. Lefebvre, any experience with delayed coronary obstruction and how can you evaluate that?
We are very experienced, but we don't know sometimes we just light and maybe it was due to less.
Dear doctor, your time is up.
In this
2 minutes,
particular
sir, 2
case,
minutes.
I think there is a big risk for the left main, and we already see some stenosis exhaustion. And this view is not a good view. So you need to go in an areocranial or iliocranial view to check the osseum of the left main. And get set for a left main stent immediately. Because you may have this kind of view which is very reassuring, but in a cranial view, you see that there is 90% obstruction with a leaflet which is opposed to the left main. So I will check the cranial view and maybe stent the left main. Absolutely. So this view is reassuring, but maybe false reassuring.
I'm totally agree, but the left main is left main. If we have something in the left main, the patient will affect it directly on the table. This first. Second, for left main occlusion, this patient now for 4 months is full up, and he's okay. Chest pain, no. His hemodynamics is okay, and his ejection fraction improved. And what I am thinking here is that I did epicranial before injection, before deployment of the valve, and I saw that the left main is slightly affected from baseline. The left main is not totally healthy. It has a lesion, so I keep the left main like that, and the patient improved, and I will show another thing that this patient, usually we have a safety wire from the passive side when we doing pro-glide, and this is trauma wire inside, and during doing compression there is
Dear
much
doctor,
bleeding.
your time is up.
Okay, much bleeding. So what we did, we ordered to give protamine, but the wire inside, and this is a very big mistake. You have to get all your stuff outside to give protamine. So what happened here? There is total occlusion. The assistant told me that there is no pulsation on the external iliac. So I found this. So, okay, I did the balloon, and after that, this is the end result. Distal pulsation with no bleeding, arterial duplex revealed, intact peripheral tree. Patient did well and discharged from hospital after 48 hours. 1 month later, his ejection fraction is 50%, no aortic regurgitation. My take-home message: the elephant in the room. Now we have TAVR option for those who had no TAVR option. What will we do now for those who are deemed too high risk for surgery like this patient? In fact, we had a lot of lessons from such of those cases. Thank you.